I think there
Good
is some
afternoon,
background
everyone present
noise.
here. I am Faraz from IGCP Group. Welcome all the participants on today's live session. And let's welcome today's speaker with great honor, none other than Dr. Arvind Gupta, sir. And let me share some of the achievement of sir. Sir has done MD, FRCP from Glasgow, FRCP from Edinburgh, FACP from USA, FICP, FACE from USA, and he is senior consultant at the Department of Cardiology RHL Rajasthan Hospital, Jaipur. And today he is going to speak on a very important topic, that is comprehensive diabetes management beyond HbA1c. To know more about this topic, I would like to invite sir and hand over this session to sir. Sir, stage is yours. You can proceed from here.
Thank you. Hello, friends. What I'll be talking to you on a very, very important topic of how to manage diabetes and specifically type 2 diabetes beyond HbA1c. That is the most important thing. A person who is practicing diabetes should know most of the things what I'll be talking just now. Uh, these are my disclosures. Of course, there are no financial disclosure for this particular topic. Dear friends, first of all, the important thing is that the diabetes epidemic is growing all over the world. Not only the world, our own country is experiencing the exponential growth of number of patients of diabetes, and that is a very worrisome situation in the future. What I want to show you just now, we have recently published a study known as ICMR in diabetes study, which is one of the largest study in the world. And I was the principal investigator for Rajasthan state. And what the Rajasthan state or all of the country showed that the prevalence of diabetes is increasing like anything. If you see my own state, Rajasthan, experiencing the 6.8% of diabetes. But the important thing is not the prevalence is not that high as compared to other states like Delhi, Sikkim, and Tamil Nadu and other states. But the important thing is that we have the pre-diabetes, which is the people who have the fasting blood sugar around 100 to 125 and postprandial blood sugar between 140 to 199. And that pre-diabetic population is supposed to develop frank diabetes within next 5 years. And what the state said that 16%, one of the highest in the country, is the prevalence of pre-diabetes in our country. So diabetes is growing, and we want to manage the diabetes as an art of management. We have to learn the art of managing type 2 diabetes. So what is the important thing is that it is not the glycemic control per se. It is the cardiovascular disease. It is the renal disease and some of the comorbidities which are very, very important. Another thing, as the diabetes person is growing older age, he is having the heart failure or some of the cardiovascular events like myocardial infarction, angina, peripheral artery disease, or some renal complications, then the management is little more difficult. However, with the recent advancement, two important molecules, GLP-1 receptor agonist and SGLT2 inhibitors, are there to rescue these events of cardio or renal complications and diabetes. Of course, the magnitude of benefit is enormous, I can say, with these two molecules. I'll be discussing in the following slides. So let us see what is the type 2 diabetes. First of all, type 1 diabetes, plainly we know that they don't have insulin secretion, or beta cells are not secreting insulin in type 1 diabetes, and they, right from the beginning, they have the propensity to develop the diabetes complications. Within 5 years or so, they start developing micro and macrovascular complications. But type 2 diabetes is a different disease. It is a chronic and progressive disease. And what this is says that here, that as you see here, the the type 2 diabetes is characterized by the progressive loss of insulin secretion. If you see here, the beta cell function is decreasing like anything. Even I can say that right at the onset of diabetes, what is important thing is that 50 to 60% beta cells are already lost in type 2 diabetes, and rest of the 30 to 40% beta cells are only remaining in those type 2 diabetes patients right at the diagnosis. And not only that, now some of the macrovascular complications even they start developing even before the diagnosis of diabetes. And just most of the microvascular complications also start developing just before the onset of frank diabetes. Dear friends, this is very, very important. You have to remember that beta cell function, we have to preserve what is the remaining beta cells in the type 2 diabetes patients. So nowadays, diabetes management is revolving around the cardiorenal metabolic comorbidities, and this is very, very important thing. If you see here, there is a continuum of cardiovascular and renal complications starting. And if you see here the epidemiological proportions of prevalence, at least 1 and 3 have the chronic kidney disease in most of the type 2 diabetes patients. 1 in 8 with normal EGFR, they develop rapid decline in EGFR. And at least 1 in 2 cases of CKD, they have low to moderate level of albuminuria. Not only that, 1 in 7 have heart failure. You are right at the incipient. And 1 in 2 have the left ventricular diastolic dysfunction. At the metabolic level, most of the people, 3 in 5 have metabolic associated liver disease. And this is very, very important. These days, NAFLD and fatty liver is known as MASLD. 1 in 4 is having the clinically significant liver fibrosis. And of course, 2 and 3, most of the people of type 2 diabetes have the dyslipidemia. And of course, if you see here, the as far as the cardiovascular disease can, 1 in 3, yani 1/3 of the patients have cardiovascular disease, 1 in 1/5 are having the coronary artery disease, and 1 in 2, almost 50% have the mortality due to cardiovascular disease. So there is a continuum of cardiorenal metabolic risk, even right at the start of type 2 diabetes patients. If they have the hypertension, obesity, and dyslipidemia, they develop immediately the endothelial dysfunction. And due to endothelial dysfunction, atherosclerosis or most of the plaques occurs, and because of that, patient develop the coronary artery disease, and they are either developing the myocardial infarction or stroke, or left ventricular remodeling, ultimately lead to heart failure. There are two types of heart failure patients in type 2 diabetes. Either they have the preserved ejection fraction heart failure, or they have the reduced ejection fraction heart failure. And ultimately, there is a mortality. Most of the half, 50% or more than 50% patients die in type 2 diabetes because of cardiovascular disease. Not only that, in the field of, through the kidney, they start developing microalbuminuria initially, and as the disease progresses, macroalbuminuria sets in those type 2 diabetes patients. They develop the chronic kidney disease, they develop the renal failure, ultimately lead to end-stage renal disease, and they need dialysis. Dear friends, this is the situation in most of the type 2 diabetes patients. Hence, diabetes is not just the glycemic control. If you are thinking that just controlling blood sugar is enough, no. Only controlling blood sugar is not enough, or glycemic control, only glycemic control is not enough. So what should be our approach? Dear friends, we should not have that the glucocentric approach in those patients. And what does it mean? It does mean that we have to address the basic pathophysiology of diabetes mellitus. I'll just come, and I told you we have to preserve the remaining beta cell which is present in type 2 diabetes patients. Now we have to cater the various comorbidities or manage the various comorbidities like renal and liver involvement. And of course, the reduction in glycosylated hemoglobin, fasting and postprandial sugar is important. I do not deny it. But other than the glycemic management, you have to think of cardiorenal and other comorbidities. Of course, we should, whatever the managing with the drugs or lifestyle modification, we should manage with the minimal risk of hypoglycemia. And of course, if patient is overweight or obese, meaningful weight reduction is definitely needed. That is the holistic approach in managing type 2 diabetes patients. And what we are saying that here, hyperglycemia is not only because of the beta cell dysfunction or not only because of the insulin resistance. It can be because of alpha cell secretion from the pancreas, that is the glucagon, or that may be because of gastrointestinal tract, either the decreased absorption or because of the incretin defects. It may be because of insulin resistance at the adipose tissues level, or maybe increased lipolysis. It may be because of increased insulin resistance developing in the muscles, skeletal muscles, or liver is the most important site for glucose production. That is known as hepatic glucose production. And that is, if it is defective, it lead to hyperglycemia. And of course, the important aspect is the kidney. That also involves in the hyperglycemia through the sodium glucose transporter inhibitors. So there are several defects in the type 2 diabetes patients. So not only the blood pressure, the blood sugar control, but we have to cater the other defects which can lead to hyperglycemia. So dear friends, we have to have the holistic person-centered approach in type 2 diabetes patients. And most of the international guidelines clearly mention whether they are ADA, whether it is the EASD, or whether our own Indian guidelines, which is I am also the steering committee member of RSSDI, we always have that type of holistic approach in the type 2 diabetes patients. So not only that, of course, lifestyle modification is the first step of starting the diabetes management. And later, we have to cater other defects. So this is RSSDI wheel. I'll go into the little later with the same thing, but right at this point of time, what we have developed this RSSDI therapeutic wheel. That means I think I advise to my most of the colleagues to keep this slide or this presentation or the printout of this therapeutic wheel to every person on their table top. Why? Because it gives the direct treatment options in the management of type 2 diabetes patient. And what if says that here lifestyle modification is the most important center. Every diabetes patient needs the lifestyle modification. And of course, most of the patients need metformin, except the patient who has the chronic disease. So in those cases, we actually do not start metformin, or if metformin is given, we have to reduce the doses. Then there are A, B, C, D, E, F, G, H approach. And what this approach says that A means as the age advances, what options of drugs you can use. As the BMI, as the patient is becoming obese, then what are the options of the drugs? C means chronic kidney disease. D means duration of diabetes. As the duration of diabetes increases, you have less and less options of having drugs available for management. E means you have the established cardiovascular disease. F is very, very important. This is only in the Indian conditions where we have a resource constraint, means they have the financial constraint of the patient. In those cases, we have to use those drugs which are not very, very costly and should be very affordable to each and every patient. And of course, H means hypoglycemia. So, and the G means glycemic status. So, I'll come into the little later about this all things. And now the multifaceted approach is essential. So, not only the glucose control, dear friends, we have to control the lipids, we have to control the blood pressure. These three things are very, very important if you really want to manage type 2 diabetes patient or to reduce or delay the micro and macrovascular complications in type 2 diabetes patients. So what are the important aspects? We have to manage most of the metabolic, of course. This is very, very important. The glycemic control is the most important part and partial of type 2 diabetes or diabetes management. But you have to manage the cardiovascular as well as the renal complications in type 2 diabetes through lifestyle modification. The first and foremost is the reduction of the tobacco, or just start motivate your patients to stop smoking or tobacco chewing. Of course, motivate your patients to have the physical activity and diet management, which is again a very, very important part and partial of management. And I'll tell you again that we have recently published a study on diet and physical and yoga in type 2 diabetes management. I'll show you some of our results. Essential treatment, of course, lipid management, glycemic control, blood pressure reduction, and weight management. All four are the pillars for the management of type 2 diabetes patient. And what the drugs for us? We have the best of the drugs available at present: the SGLT2 inhibitors, GLP-1 receptor agonist. Of course, for blood pressure, RAS blockade is there, and recently mineralocortical receptor agonist is also available for the management of heart failure. So it should be a coordinated approach between the lifestyle, risk factor control, and the essential drug management. So we have to go with this approach, A, B, C, and I extend little bit that there should be D means diabetes, diet management, and E means exercise or yoga. So A, B, C, D, E approach should be there, and let us start with the management. So glycemic management, I told you, this is the most important thing. And but monitoring, and what are the different parameters? Blood sugar is not the only parameter, because blood sugar is fluctuating like anything. If you see here, the most of the time we cannot detect with the self glucose management by glucometer. So we have to go with the continuous glucose monitoring. So monitoring should be either through the self blood glucose monitoring by glucometer, by fasting, before lunch, post lunch 2 hours, or before dinner, blood sugar management. Of course, we can do most of the management by these four parameters. But sometimes the fluctuation is so much that our undetected hypoglycemia, maybe in the night time, we cannot diagnose. And now we have the best of the uh, therapeutic available gadget is available, known as continuous glucose monitoring available. 14 days we can put a chip on the arm, and this gives us the minute to minute blood sugar monitoring. So there are several limitations to HbA1c. What I was telling just first month, that we have to control beyond HbA1c, because HbA1c is number one. It is a prognostic. Not most of the time it is not the diagnostic. Of course, there are differences of HbA1c in different ethnic groups. Hence, we cannot standardize the HbA1c in one group to another group. And of course, the prediction of complications, we cannot predict. There is no cutoff HbA1c that this cutoff HbA1c will develop retinopathy, nephropathy, or other micro and macrovascular complications. Hence, HbA1c is, of course, important, but it's not that important. We have to go with the continuous glucose monitoring and other system. And the most important thing comes through the CGM is the time in range. So time in range is the most important thing, a parameter to see whether patient is developing micro and macrovascular complication. Dear friend, it is done through the continuous glucose monitoring system, and probably 75% or 80% time in range is most important. And most of the patient we have seen that the patient who have range in the 75 to 80%, they develop less or they have the delayed micro and macrovascular complications. And there are few papers evidences available that diabetic retinopathy, the patients who have a good time in range develop less retinopathy. Now we want to see most of the available anti-diabetic drugs and what are their effects on the cardiometabolic renal factors. We must learn all these factors and what these factors suggest to us. These factors are first and foremost is the after lifestyle modification. It is the metformin, and we know that now we know most of the molecular aspects of metformin efficacy. The macrovascular efficacy is through reducing the adipose tissues or adiposity. It reduces the insulin resistance. It increases the fibrinolysis and reduces the plaque lipid deposition, and it improves the lipid profile. Of course, on the microvascular aspects, it reduces the hyperglycemia and glucotoxicity, and it improves the microcirculations. And dear friends, through all these effects, it reduces the oxidative stress, reduces the inflammatory cytokines, reduces or improve the endothelial function, and hence it is very, very useful, metformin. And now we have several clinical evidences in front of us, start from the UKPDS and reach registry, which clearly says that metformin is a very, very important aspect. So, and UKPDS clearly says that it is the metabolic memory. Please start managing diabetes as early as possible. Don't wait for the patients to develop the micro and macrovascular complications, because there are the legacy effects. Second important drugs available to us is the DPP-4 inhibitors. They were released in 2008, and we are using these DPP-4 inhibitors. They are very, very good molecules. The important thing is that they are weight neutral, and the efficacy as far as reduction in blood sugar is modest. And most of the clinical studies have clearly shown that the DPP-4 inhibitors are a good molecule for the management of type 2 diabetes. Now, I told you right at the beginning, we have the two most important, very good molecules, SGLT2 inhibitors and GLP-1 receptor agonists. Only these two molecules have shown the, of course, the glycemic control is there with these two molecules, but the cardiorenal benefits are definitely there with these two molecules, not with any other molecule. So SGLT2 inhibitors are very, very important molecule. And what are they? What they do for managing type 2 diabetes or reduction in the blood sugar. And this is a very simple diagram which says that the glucose actually through the reabsorbed through the SGLT2, and most of the time most of the glucose which is there in the proximal tubule reabsorbed. But if you inhibit these SGLT2 and SGLT1 channels, then whatever the glucose is reabsorbed, it is not reabsorbed and now excreted through the urine. A very simple mechanism is there, and most of the EMPA-REC and VAS declared there are several SGLT2 inhibitors, empagliflozin, dapagliflozin, canagliflozin. There are several SGLT2 inhibitors which are the one of the best drugs which reduce the cardiorenal effects to the tune of around 46%, which is unmatchable to any other molecule. Another molecule I told you is the GLP-1, which is secreted by the L cells of the intestine, and through the incretins here, the L cells of the intestine, the incretin hormones, this is through the GIT tract, the GLP-1 is secreted. But there is a DPP-4 enzyme which immediately uh, destroy the GLP-1 so that it is rapidly inactivated and the patient does not have the ability to have the efficacy of GLP-1. So now we have the GLP-1 receptor agonist with us, and what the cardiovascular benefits? Their disease of the pipes means it reduces the myocardial infarctions, reduces the pump means it reduces the heart failure through the diabetic cardiomyopathy reduction, the fibrosis reduction, and stiffness reduction, and reduces the heart failure. So GLP-1 receptor agonists have shown the cardiovascular benefits beyond any other molecule. And if you see here, there is a what are the pharmacodynamic effects? If you see here, the insulin secretion is maintained, and not only that, it reduces the appetite, reduces the food intake, and the weight loss is tremendous, as good as the bariatric surgeries, and it increases the gastric emptying. Hence, it is very, very useful. So both SGLT2 inhibitors and GLP-1 receptor agonists are very, very good as far as the weight reduction is concerned, and glycemic control and cardiorenal benefits. Other drugs, I'll just mention it now. Antiplatelet therapy for the primary prevention if patient is already having the high risk, or secondary prevention if the patient is already developed the myocardial infarction or angina. Second important aspect is the blood pressure, which is again very, very important. And most of the UKPDS and other clinical studies have shown the beneficial effect of blood pressure lowering through several drugs, but ACE inhibitors or ARBs actually topped the benefits of blood pressure reduction as well as the cardiovascular benefits. So ACE inhibitors and ARBs are the drug of choice. Of course, other than the diuretic, calcium blockers, and other drugs are also very important, sometimes to reduce the blood pressure. Another aspect is the lipid control. And lipid control we have seen with most of the studies, including our own ICMR in diabetes study, which have seen that the lipid control actually ultimately lead to reduction in the plaque formation, reduction in the atherosclerosis, hence reduction in the development of plaque and reduction in the myocardial infarction and angina. Also, the mortality is being reduced. So, for the primary prevention, if lipid is, especially the LDLC, if more than 70, please start the statin. Or if patient is on the high risk group, even in the secondary prevention, we have to start the statin in most of the type 2 diabetes. So, dear friends, I want to let you again emphasize of healthy and lifestyle management is the most important aspect of type 2 diabetes management. Smoking suggestion and alcohol stoppage, physical activity enhancement, blood pressure reduction, A1C control less than 7%, or I can say it is 6.5%, and start statin ACE inhibitors or ARBs to most of the type 2 diabetes patients. Start with the behavioral therapy. Sodium reduction is very, very important. Weight loss, 5 to 10% weight loss is a necessity for most of the type 2 diabetes, overweight and uh, uh, obese patients. Now, this is one of the study I want to show you. We have recently published this study, the effect of yoga and the exercise and the diet management, of course, in type 2 diabetes prevention. We have followed pre-diabetic population for 3 years. Every 3 months, we followed these patients. And what we found in these things is that if you see here, the prevent 40% reduction in the development of type 2 diabetes in 3 years, which is not seen with any study till date in the world. ACE inhibitors, the ACE algorithm in 2023 clearly start that lifestyle intervention and divided into two categories. If patient is having high risk of cardiovascular disease, start immediately the GLP-1 receptor agonist, SGLT2. If patient is heart failure risk, then SGLT2 inhibitors. If patient is already having stroke, GLP-1 receptor agonist, CKD, SGLT2 inhibitors, and GLP-1. And then, if they are not controlled with these two molecules, start using another molecules, whether it is sulfonylurea, metformin, whether it is AGI, alpha glucosidase inhibitors, and other drugs. Even ADA in 2024 says the similar thing. Now I told you again our own RSSDI therapeutic wheel, which says that lifestyle modification, metformin, and depending on the comorbidities and other conditions, you can start using this drug. This therapeutic wheel is very, very important for any primary care physician on their desktop. And now this is the again the holistic, my comprehensive slide, that you have to detect the comorbidities and risk factors when the patient comes to us for the first time, whether they have obesity, hypertension, dyslipidemia, fatty liver, OSA, or other sedentary lifestyle. Once you detect the comorbidities and risk factors, then start screening the complications, whether the patient is having micro or macrovascular complication. And once you now screen the complications of the patient, now please start the rational therapy depending on the comorbidities or the complications. Patient may require glycemic control, blood pressure control, dyslipidemia management, and antiplatelet therapy. And of course, once holistic management through the lifestyle, you have to go with the target HbA1c less than 7% or 6.5%. The blood pressure target should be met. Lipid target LDL-C should be less than 70%. Lifestyle intervention is a must. I told you the our own studies on lifestyle intervention, and of course medical nutrition therapy, the diet management, and the physical activity. I think this is the whole thing, holistic management of type 2 diabetes. And my last saying, managing diabetes with diligence is not just a prescription for a healthier life. It is a shield against the intertwined challenges of cardiorenal complications, offering hope for a future free from their grip. Thank you very much for your patience listening. I am here for answering your questions. Thank you. If there are any
Thank you
questions,
so much, sir, for taking out your precious time and sharing your insight on this topic. I definitely think this session knowledge is going to help all the participants on their practice also. Sir, as I can see, sir, we have received some questions, sir. With all your permission, shall we take this session?
yeah, yeah, please, please.
Yes, sir. The first question I can see is from what need to done for the assessment for patient with HbA1c?
Your voice is not clear here. Faraj, can I see the question?
Am I
Can I
am I
see the
audible now?
question? Yeah, you are audible now. Yeah,
Can you
please.
hear me, sir?
Yes, yes,
Can you hear me? Yes,
yes,
sir. The
yes.
question is from Dr. Subramaniam. He's asking
Yeah,
what are the clinical examination need to be done for the initial assessment for patient with
yes,
HbA1c.
yes, yes. So, very good questions. Whenever the patient comes to us for even for the first time, I think the clinical examination is important. You have to have the pulse, blood pressure, and all the vital parameters. Go for the BMI, or simple waist estimation is the most important aspect. The clinical examination, beyond clinical examination. Now, first thing is, of course, the blood sugar monitoring. The blood sugar can be fasting, post-prandial 2 hours, and pre-dinner. I think these three parameters are important. After that, you have to go with the lipids. I told you the blood pressure, and they are very very important aspects. And depending on the patient's individual condition, depending on the patient is lean, obese, or overweight, what are the different types of management, depending on their blood pressure, whether they are having normotensive, whether they are hypertensive. Depending on that, we have to start with the ACE inhibitors, ARBs. So the blood pressure, lipids are more important. I told you it is the LDLC should be less than 70 in most of the diabetes patients. That will prevent the patient to develop the heart plaques or atherosclerosis. Then other than that, the you should go with the heart failure. So echocardiography here, the two-dimensional echocardiography is very very important. Don't ignore the findings of those echocardiography, whether the patient is having early diastolic dysfunction, what are the ejection fraction. I told you even heart failure is incipient in most of the time. Asymptomatic heart failure is there. So you have to detect the heart failure. If even the normal ejection fraction heart failure and reduced ejection fraction heart failure, in both the condition you have to start the SGLT2 inhibitors or mineral cortical receptor agonists. So these are the few drugs you have to start right at the beginning of, even right at the onset of type 2 diabetes patients. So go with the most of the ECG is very very important. So most of the investigations you have to go do other than the clinical examination, that will give you the idea of what drugs patient need, what lifestyle patient need, what the diet patient, our diet management or medical nutrition therapy patient needs through this whole approach of investigations. Yeah.
Thank you so much, sir, for answering this question, sir. We will be taking one another question from Doctor
Yes.
Shrishti.
Yeah, please. Faraj, I can't hear you.
Sir, what is the
Yeah,
role of sir? What is the role of lifestyle role to treat HbA1c patients?
yeah. So I told you our own study, which we have recently published. I shown you the results of those study known as IPDS, Indian Prevention of Diabetes Study. This study was done at 6 centers in our country, including Delhi, Jaipur, Trivandrum, Bombay, Hyderabad, and most of the cities. And what the study conclusions are that we have followed, I told you, the pre-diabetic population. We advise for every 3 months the patient yoga, the lifestyle management, and diet management. And we followed these with all molecular tests we have done every 3 months to those patients. And what we have seen, the tremendous 40% reduction in the conversion of pre-diabetic population to diabetic population. Even some of the early diabetic population, which we have instituted the diet and lifestyle into those early type 2 diabetes patients, they not only develop the remission, but some of the people, they have come to the normal HbA1c. What is the tremendous effect of lifestyle management? This is the most important aspect beyond glycemic control. Every person should reduce, I mean, they motivate to stop smoking, reduce alcohol, and of course, the walking. Walking is very well, 30 to 45 minutes walking in the morning. A brisk walking is required to reduce the chances of development of cardiovascular complications in diabetes. And through the diet, I told you, the diet, the salads, the fibers, fruits are the most important aspects in the diet management. Yeah.
Thank you so much, sir, for answering this question. I hope, sir, it will be very much helpful to all the audience who are hearing. And sir, as I can see there is no more question, sir.
Your voice is breaking actually. I can't hear you.
Shall we conclude this session, sir? As I can see there is no more question,
Yeah,
sir.
sure,
Thank you
sure.
so much, sir. Thank you
I
so
hope,
much for your valuable
yeah,
time.
I hope
And
most of the patients will understand and follow some of
we would like to see you in
the
future on different topics, sir.
sure, sure. Thank you.
Okay, sir. Thank you so much, sir. Have a great day, sir.
Okay.
Thank you.